So good morning, everyone. Actually, Dr. Digvijay has unfortunately been tested positive for COVID. So yesterday he requested if I could present his talk. So really unprepared for this talk, but whatever I teach my residents, probably I will try to teach here. So this is on behalf of Dr. Digvijay. This was his presentation. And Dr. Digvijay, as we all know, is the past president of AIOC and is the director of Noble Eye Care. So I would like to present instead my talk, which... So basically in this plasty session, we are adding a pinch or a flavor of neuro-ophthalmology. So just because there could be overlapping signs and symptoms, and so even the plasty people should have the idea about the neuro-ophthalmic signs and the various, the manifestations of these diseases. So before we go on to the abnormal disc, first you should understand that what a normal disc looks like. So I think you all must have, as residents, must have seen the normal fundus. You have a well-discrete margins, you have a cup, you have a neuroretinal rim, and of course the vessel surrounding it. So if you know the normal anatomy, then you can come on to the abnormal anatomy. So this is a disc edema, or whether it's a disc pallor. So first starting with the disc edema. So supposedly a case of disc edema comes to you. So you should know that whether it's a case of a true disc edema or a pseudo disc edema. The confusion especially is there when the early cases of papilledema present to you. So they have a very subtle blurring of the disc margins. The vision could be 6/6 in such cases. So how can you differentiate? Because there are a lot of conditions that cause pseudo papilledema. And so the conditions, the most common one is a optic disc drusen. Then there could be pseudopapillitis that you commonly see in cases of hyperopia. So hyperopic discs are small discs. There is a crowding of the nerve fiber layer, and so you see a very blurred disc margin. So we have seen a lot of children, 6/6 vision, diagnosed as papilledema and under treatment with Dimox. So, so it is better to keep such patients on follow-up if you have any doubt in the diagnosis. And on follow-up, look at the fundus picture. If the fundus picture is changing, it means there is some disc edema. But if the fundus picture remains the same, probably it's a pseudodisc edema. And of course, have a look at the vision, color, contrast, and other of the aspects of vision like VP and the visual fields. Then other mimickers of optic disc edema could be abnormal discs like morning glory syndrome, myelinated nerve fibers, or a tilted disc anomaly. So other things that can help you in differentiating pseudo from true papilledema is a fundus fluorescein angiography, where you will see a evident disc leak, and also you can also identify disc drusens on autofluorescence. Then what are the signs of disc edema? There could be mechanical, then there could be vascular signs. So coming to the mechanical signs, these are the basics, you will see the elevation of the disc or the elevation. So in fact, the most initial sign that you will see would be the filling up of the optic cup. So normally a cup which is visible, but if the fluid fills in, the cup tends to fill up. So that is one of the earliest signs of optic disc edema. Then you see the elevation of the disc margin, the blurring of the disc margin. Now what are these lines that you see over here, these folds? Yeah, so these are the patterned line. So in doubtful cases, we also look for these patterns lines, which are retinal or choroidal folds because of the elevation of the disc. And you can also probably sometimes make out the edema of the RNFL. Then vascular signs, what will you see? There is hyperemia of the disc. There could be venous toxicity, congestion. There could be exudates, not only peripapillar, but also macular exudates. There could be nerve fiber layer infarcts and other vascular abnormalities. So remember that do not limit your examination to a direct ophthalmoscopy. Always do a dilated fundus examination because it will give you a better picture of the pathology. We had recently a case referred as a case of optic neuritis. But when we also thought that there is a disc edema, admitted the patient for management. But when we did a dilated fundus examination, we realized it was a case of a choroiditis. So choroiditis that was causing a disc edema. So although the management remains the same, the IVMP was given, however, the prognosis would be different. So then how will the patient present to you? The symptoms would be decrease in vision. Sometimes they can have transient visual obscurations. There could be diplopia, especially if there's a raised intracranial pressure. The patient can present with a sixth nerve palsy, which is a false localizing sign. So there will be a horizontal diplopia and can sometimes also complain of visual field defects. So a history, well, like any disease, history is a very important aspect, and it gives you a clue regarding a lot of pathologies, like whether it's acute onset, subacute, or a chronic onset. Something which is acute or subacute, you would think of a traumatic or a vascular pathology. Something which is, more chronic and progressive, you will think of something which is slowly growing intracranial tumors or some other pathology. So depending on whether the disc edema is unilateral or bilateral, the differentials are following. Unilateral, most important differentials are a papillitis, ischemic optic neuropathy, venous occlusions, intraocular inflammations, or infiltrative or traumatic sometimes. In bilateral, papilledema. Now there are several causes of papilledema that you should rule out. Intracranial space occupying is the most important thing that you should rule out. Then venous sinus thrombosis, malignant hypertension due to raised blood pressures. And if everything comes out to be normal, then probably it's a case of idiopathic intracranial hypertension. Sometimes diabetic papillopathy can also have bilateral blurred disc margins. So a case of bilateral disc edema comes to you, what should be the line of management? So bilateral disc edema, remember, is always an indication for a neuroimaging. What type of neuroimaging? I think a lot has been covered in the previous talks, but contrast-enhanced MRI of the brain and orbits. So that's very important. Okay, and orbits, as already stressed upon, it should be fat suppressed because you want to have a look at the optic nerves. So you do the neuroimaging. If you find a space occupying lesion, you have got the cause. If not, then you have to get a lumbar puncture or a CSF analysis done. You don't do it, you refer the patient to a neurologist. The neurologist people will assess for the cells, abnormal proteins, and if everything is okay, also check for CSF manometry. Many a times they miss out on the CSF manometry, the opening CSF pressures, because the proteins and cells could be normal, but if the opening pressures are elevated, this tells you that there is a raised intracranial pressure. So there has to be some cause related to it. Then in that case, if it's a raised intracranial pressure, you have to do a MR venography. So venography will identify that whether there's a venous sinus thrombosis that's causing a raised ICT, and if not, then probably it's a case of idiopathic intracranial hypertension. And accordingly, the management would depend. So there are the clinical staging of papilledema. It could be early, advanced, chronic, atrophic. Early, as the name suggests, mild blurring, which is often confused with pseudopapilledema. Advanced stages, you have established swelling, discrete hyperemia, extensive retinal hemorrhages, exudates. In chronic cases, the exudates tend to increase, and the disc starts getting a little pale. And finally is the atrophic stage, where the atrophy sets in. You will see extensive gliotic changes, and it's a secondary optic atrophy. So this is one case. The patient presents to you with bilateral decrease in vision. You examine the eyes, you see a bilateral disc edema. There are field effects. You go ahead with neuroimaging. So what you see in the neuroimaging here is there is a prominence of the optic nerve sheath. And in fact, there's also a reverse cupping that if you can see here, there's a reverse cupping which is evident that is suggestive of a papilledema. And another sign, can you describe what sign is this? So this, that's actually a partially empty cella. So this is the place where you should have the pituitary. And pituitary should have a similar intensity as the brain. So what you see is just it has been limited to the thin strip of tissue, and it's mainly filled with CSF. So it's a partially empty cella sign. It may be seen in normal individuals, but in the presence of papilledema, it's suggestive of a IIH. Okay? So one of the soft signs for IIH. Then, of course, you do a MR venography. You rule out a venous sinus thrombosis. You might, say that here on the left side, it appears to be a little thinner, but it's actually a hypoplastic venous sinuses, which is again often confused with venous sinus thrombosis, and patients are overtreated. So hypoplastic venous sinuses is a normal thing, which may be seen, but it doesn't cause a raised ICT. So the MRV is essentially normal in this case, so it's a case of a idiopathic intracranial hypertension. So the typical patient profile is a young obese women. The causes are obesity, then certain drugs can cause it like vitamin A, growth hormones, carbidopa, etc. The patient presents to you two most important complaints: headache, vision loss. Okay? CSF opening pressures more than 25 centimeters is considered to be significant, and there's also a criteria for IIH that you should go through. How do you manage it? Medical management, you use carbonic anhydrase inhibitors and other diuretics to lower the ICP. If it doesn't work, then we do optic nerve sheath fenestrations. And if not, then you go ahead with the VP shunt surgeries. Then coming to another case, but here what you see that this patient had a bilateral disc edema, but what is unique is that you see a lot of cotton wool spots and extensive hard exudates. So this goes more in favor of a raised blood pressure. So because there is presence of hypertensive retinopathy as well. So it's important when a case of papilledema comes to you, especially in young patient, also get a blood pressure checked. Then diabetic papillopathy, although they will present with bilateral disc edema, but usually it's a benign condition, does not affect the vision, it is reversible, and younger diabetics are more susceptible to it. Optic neuritis, well, in optic neuritis, it could be typical or atypical. Now, the typical one, as you see, the patient has this complaint, a young female patient presents to you the initial deterioration for initial 1 to 2 weeks, and thereafter the recovery begins spontaneously. So that's a typical course, okay? So in a typical disease, so whether it's an optic neuritis, then whatever doesn't fit into the typical picture becomes a atypical optic neuritis, like extremes of ages, then bilateral optic nerve involvement, then if there is a poor vision recovery, a very severe vision loss, all this becomes atypical optic neuritis. Whether typical or atypical, you need to get a contrast enhanced MRI of the brain and orbits, okay? In fact, in atypical cases, you can also get a contrast enhanced MRI of the spine, because you have to rule out the transverse myelitis, like in cases of NMO spectrum diseases or MOG positive cases or MOG cases, okay? So, how will they present to you? They will present with a decrease in vision, mild tenderness on eye movements, central centrocecal scotomas, and this is basically a typical picture that you will see in a multiple sclerosis. So typical demyelinating lesions which are perpendicular to the periventricular area, these are called the T2, Dawson's fingers. And also what you see, as Dr. Akshay has just discussed, there is a enhancement, post-contrast enhancement. So that's why contrast becomes very important, because when you see this enhancement, you know that it is inflammatory. So one case, we see a 56-year-old male patient, diabetic, hypertensive, presents to you with a sudden decrease in vision that was noted on waking up in the left eye. So you check this fundus and you know the diagnosis is glaring at you. What do you see over here in the left eye? It's a pale disc, but what type of atrophy do you think it is? Secondary optic atrophy, yes. You get the visual fields, it's a kind of a inferior altitudinal field defect. So this is a case of a NAION, okay? Then, so NAION is a non-arteritic ischemic optic neuropathy, a very common condition that you will see in elderly patients. So unilateral disc edema in elderly patient most likely is a NAION. Then important differential for NAION is a arteritic ischemic optic neuropathy. So arteritic is a medical emergency, it's a life-threatening condition. The management is very different for the two. For NAION, you essentially don't do anything and might give a trial of steroids if the patient is not diabetic. But in arteritic, it's a medical emergency, you have to treat the patient immediately with IVMP, methylprednisolone. So how to differentiate? You get the, usually the vision loss is very, very severe. In cases of arteritic, patient might have other systemic symptoms like, you know, the jaw claudication, the tenderness in the temporal side of the head. And so you have to get ESR CRP done, because if the ESR CRP is markedly elevated, that goes more in favor of arteritic. Usually the age group for arteritic is an elderly patient, 70s and above. And that's how you differentiate. But if it's a case of NAION, which you more commonly see, you have to rule out the systemic risk factors like diabetes, hypertension, hyperlipidemia, hyperhomocystinemia. Get these blood investigations done. So now coming to pallor. Well, pallor, it could be primary, secondary, consecutive. Primary, well, it is related to a compression which is happening behind the optic nerve head. So in fact, the new terminologies that we are using is optic atrophy associated with disc edema and optic atrophy not associated with disc edema. So optic atrophy which is associated with disc edema is secondary, and we have just discussed the causes. Optic atrophy without a disc edema, well, includes your hereditary, nutritional, toxic, and consecutive is the one that occurs secondary to retinal or choroidal diseases. So the one such example of glioma, I think this has been covered, a case of glioma causing a unilateral optic neuropathies. I'll just discuss the cases. A patient presents to you with a bilateral decrease in vision. There was no history of alcohol or drug use that might have led to a decrease in vision. Pupils were affected, vision was affected. So what you see is a markedly stark pallor, okay? Although there's cupping, you might get confused with glaucoma, but what you see is a marked cupping, and marked pallor, and there is a bitemporal hemianopia, so you immediately get a neuroimaging done. So this kind of a field effect respecting the vertical meridian has to be neurological. So that's a suprasellar mass, most likely a macroadenoma, pituitary macroadenoma. So another case, a young patient who started with a decrease in vision 2 months back in one eye followed by other eye with mild fluctuation in vision. So young patient, bilateral decrease in vision, gradual onset, slowly progressive. So you see the disc, these are severely pale. So again, your first step would be visual fields. You get the visual fields done, you see central scotomas. So central scotomas usually go in favor of metabolic, nutritional, toxic, etc. So, but you should always get a contrast-enhanced MRI of the brain and orbits to rule out, in case any underlying lesion is there, it's reported to be normal. So considering that most likely it's hereditary, as the patient did not have any history of drug intake, we got a genetic analysis done for the patient. It came out to be positive for LH1, okay? So LH1 you can test for 3 primary mutations, but apart from that, you can have other mutations also. Okay, so just quickly, there's last case, a patient of tuberculoma on ATT for past 2 months, and post-ATT has started complaining of decrease in vision. So what you see is a marked temporal pallor, mild temporal pallor, and on again you see the visual fields, you see the centrocecal scotomas. So this was a case of a toxic optic neuropathy. Well, again, here I would like to say that if a case of TBM comes to you, tuberculous meningitis, do get a contrast-enhanced MRI of the brain and orbits, because sometimes you can have a paradoxical reaction to drugs, where post-ATT, suddenly the tuberculomas appear or enlarge in size, and they cause a decrease in vision, okay? So that's your toxic. And just in brief, that neuro-ophthalm case comes to you. This is the basic examination. So do check for color contrast visual fields. You might not have a color or a contrast chart available with you, but you can at least use any bright object and ask the patient to see monocularly. A very simple way. Assess the pupils, assess the fundus, look for the fields. Neuroimaging, very, very important. Genetic analysis, where you're suspecting hereditary optic neuropathies. You might go for CSF analysis, especially if you're suspecting infections like meningitis. And of course, you should be able to differentiate between a glaucomatous and a non-glaucomatous disc, and that's a completely separate topic altogether, which we cannot cover today.